Hi, I'm Jacques Van Dam. Very happy to be with you today to talk about interventional endoscopy. I'd like to thank the course organizers for their very kind invitation. Let me share my screen with you. We'll get right into it. And there we go. First, I would like to say that I have no disclosures. So there were several very interesting areas pertaining to advanced endoscopy, and I thought I'd break them down into just a couple in the limited time that we have. The first has to do with gallbladder drainage. This was a topic of quite a bit of research presented this past year. As you can see here, this is the standard. Right now it's percutaneous transhepatic gallbladder drainage in patients either who are having an acute attack of cholecystitis in whom the surgeons feel they'd like to wait before undertaking a cholecystectomy to allow the inflammation to resolve. This is a temporizing method, but it also has some adverse events associated with it. As you can imagine, there's issues with the catheter at the percutaneous site. There's dislodgement of the catheter, there's infection, there's bile leakage, there's pain. And then all of the bile that drains into the receptacle is discarded. Patients are told to flush this down the toilet a few times a day, but it's not very physiological because bile is very necessary for digestion. Abstracts were presented having to do with endoscopic gallbladder drainage for exactly the same types of patients. The first is this technique. This is endoscopic transpapillary gallbladder drainage. So at time of ERCP, a catheter is placed through the bile duct into the cystic duct, and the same idea, it resides within the gallbladder. The difference here is there's no percutaneous access. There's no leakage or infection or pain at the percutaneous site, and all of the bile is being drained physiologically into the duodenum. Here's a report, a group from Japan, looking at transpapillary approach as a bridge to surgery, again for those patients who otherwise would be getting a percutaneous drain, or interestingly, as definitive treatment for patients who may not be operative candidates. But one of the conclusions of the study was that the transpapillary approach is more difficult. Percutaneous is very straightforward, very simple. If you listen to our interventional radiology colleagues, it certainly doesn't require endoscopy. So the approach seems to be much more straightforward. In this study, they looked at 323 patients who underwent endoscopic transpapillary gallbladder drainage, and they found they had a technical success rate of just over 70%. That is certainly less than you would get with a percutaneous approach. Early adverse events were far less. They had cystic duct injuries. We'll talk about that for a moment. But if you think about it, you have to negotiate the cystic duct to get your catheter into the gallbladder. The cystic duct is not just a duct, an ordinary conduit. It has the spiral valves of Heister, and that can be impediment to reaching the gallbladder. Also, in cases of cholecystitis, you will often have a cystic duct stone residing within the cystic duct, and that again is an impediment to reaching the gallbladder. Pancreatitis is an adverse event. Whenever you're doing ERCP, you're going to have some patients with post-ERCP pancreatitis. So the conclusions here, endoscopic gallbladder drainage by the transpapillary approach. Limitations are cystic duct stones and the direction of the cystic duct. As it turns out, this was one of the findings in the study. In this image I showed you previously, you can see when you're inserting a transpapillary drain, if your cystic duct is going cephalad, a little bit north here, your leverage, you're pushing the stent upwards, and you will eventually find your way into the gallbladder. Problem is, not all cystic ducts are made the same, and if the cystic duct is going caudad, if there's an abrupt angle, as there apparently is in at least a quarter of the time, between a quarter and a third of the time, you're going to have trouble getting a stent into the gallbladder. So this was what was learned as a result of this study. I thought it was pretty good. So what happens if you can't do a transpapillary, which you see here? Then you have, as you know, the option of placing a lumen-opposing metal stent from the duodenum, in this case, into the gallbladder. This is done, the technique is pretty routine, although not necessarily yet for the gallbladder. It's the technique we use for draining pancreatic pseudocysts when we make a cyst gastrostomy. And the idea here, as you can see in the figure, is we would take a device with electrocautery puncture from the duodenum into the gallbladder, deploy the distal flange of the lumen-opposing metal stent, then the proximal flange, and what you create is a very large caliber fistula between the duodenum and the gallbladder. This enables drainage of the gallbladder, also passage of stones, and in some cases access for endoscopy into the gallbladder for additional therapy. This study from Shah at the Guy's Clinic looked at endoscopic ultrasound guided versus percutaneous, the ones we've just been talking about, guided gallbladder drainage. So a head-to-head evaluation of endoscopic versus percutaneous, retrospective review of 112 patients, and they are non-operative. And again, that's just sort of where we are right now in the field. Good surgical candidates get surgery, and the surgeons refer to us those patients who, for one reason or another, are not good operative candidates, would get an endoscopic ultrasound. So we're already a bit handicapped if we're doing a head-to-head comparison. Mean age 77, just over half male. Endoscopic ultrasound guided drainage 33, and the percutaneous approach 79 patients. And what you see here in their results, here's the endoscopic ultrasound, N of 33, percutaneous, N of 79. And if you look down, all significantly different here. Less fluoroscopy time for the EUS approach, less post-procedural pain, less requirement for narcotic analgesia. And over here you see less requirement for reintervention. And the adverse events we talked about, stent migration, leakage, bleeding, pain, infection, all significantly less when you go the endoscopic route versus the percutaneous. So this is a single center retrospective, but it is showing that there's superiority of endoscopic ultrasound versus percutaneous gallbladder drainage. All right, so it's better, but if it's more expensive, then nobody's going to do it. So somebody has to do a cost effectiveness analysis. This one from Brigham and Women's Hospital, this was presented in abstract form, and this was a cost effectiveness analysis. EUS guided versus percutaneous, again, we're talking about exactly the same thing, and for high risk patients, again, for the same reason. Average target for the study, cost effectiveness for a 50-year-old man with acute cholecystitis, not an operative candidate. And their conclusions, while the technical and clinical success were similar, increased rates of re-intervention for the percutaneous, and you saw it was about 100% in the prior study, contributes considerably to the cost effectiveness of the strategy. So even though on its face, endoscopy, the endoscopic approach with all the inherent support that goes with doing an ERCP is expensive, in the majority of cases, I think it was 97% of the time, you only do it once. You don't see the patient back a second time. With the percutaneous, you always see them back. It was 100% in the prior study. And that's because even if it's effective and there's no complications, at some point, the drain has to be changed. And so that's another intervention. So cost effectiveness goes to the endoscopic approach as well. Now the big one, so endoscopic ultrasound superior to percutaneous, but what about endoscopic ultrasound-guided gallbladder drainage as definitive therapy compared to lap chole. So this one comes out of Hong Kong. I think a lot of people feel this is the direction the field is going. This is likely to be the end point, but a lot of work needs to be done. There's probably some techniques that need to be developed, some tools, but with what we have now, this was a particularly interesting abstract because it went right after lap chole. So their premise, EUS guided gallbladder drainage is favorable compared with percutaneous approach, but what about lap chole? They did a retrospective over 6 years. And for all the reasons we talked about, the endoscopic group always winds up being the sicker group because if you're an operative candidate, you get surgery. So they use the Charlson Comorbidity Index, which is a validated instrument for looking at how sick somebody is. And they tried to match sickness between the two groups. And here you can see they've done just that. So an age-adjusted Charlson score. So they're trying to compare apples with apples. And as you see, no difference in the technical success, the clinical success, length of hospital stay, no difference in the 30-day adverse events or 30-day mortality. Everything they looked at, they're very similar. So here's the first, admittedly retrospective, but it's showing that EUS as definitive therapy for patients with cholecystitis may challenge at some point the surgical approach. All right, switch gears a little bit. Let's talk about ergonomics and endoscopy. It's a growing field. I don't remember this. I've been doing this for a long time. I don't remember so much emphasis on what happens to us as endoscopists. And a couple of these caught my eye, so I thought I would mention them here. This one from WashU in St. Louis. They report that up to 90% of physicians that routinely perform endoscopy experience some type of musculoskeletal pain. What's the cause of this? So they did surface EMGs to test the strain during procedures. They looked at 183 procedures, and interestingly, they looked at hand size and experience as potential reasons for the strain. Hand size was measured by glove size. And if you think about it, production model endoscopes, whether it's Fuji, Pentax, Olympus, one size fits all, comes off the production line. This may change with disposable scopes, but currently and for decades, you had one size of scope, but you didn't have one size of hand. So the authors here looked at the contribution of hand size with respect to strain. Experience was also another item they looked at. And the results showed that small hands, people with small hands were more likely to show strain in their hands, and less experience. And the experience was judged at 300 cases, which is probably around the time of fellowship or shortly thereafter. But the fact that with more experience, you develop less strain at endoscopy suggests one of two things. One is that you're making muscles where you need them, but that can't happen after just 300 cases. So more likely, we're learning techniques about how to avoid strain. And the fact that these can be learned suggests that maybe, and this was one of their conclusions, this should be added to endoscopic training. So as we get more experience, we figure out how to reduce likelihood of injury and strain, and this should be taught to our trainees. The hand is an interesting object here for study. Okay, third space endoscopy, still with the ergonomics. These procedures are arduous. They take a long time. They are difficult to do. And we're talking about POEM here and ESD as examples of third space endoscopy, just really long, technically difficult. They're both challenging with this respect to, you know, your focus and attention. for what can be a couple of hours at least. And then what's happening with your hands and your arms and your back. This was an international study. They looked at 22 different items. And we just mentioned a couple, hand size and experience, but here they looked at 22 different items, 45 endoscopists, 10 countries, 4 continents, 98% right-handed males, or 98% male, 82% right-handed. So that's sort of where the field is right now. The mean number of third space endoscopy cases, 460 over 6 years, and almost all of these endoscopists also did ERCP in the US. And the results, over 2/3 reported musculoskeletal injuries. And of the 22 items they looked at, nothing predicted what was going to cause an injury. And here are all the different things they looked at. And unlike the last study, where hand size and experience contributed to the outcome, in this case, they couldn't find anything. It's just something that happens to these endoscopists. All right, switch gears again. This time we're going to look at EUS-guided fine needle aspiration versus fine needle biopsy. As you can see in the EUS picture, you see a needle entering the cyst and aspirating fluid. And we used to say fine needle biopsy of the cyst wall. We would pass the needle into the wall and get just a tiny little core of tissue from the cyst wall. But what this study is looking at EUS-guided needle biopsy. So here's a pancreatic cystic neoplasm. You can see the needle has entered the cyst. I'm going to highlight for you now biopsy forceps that actually go through the needle, enabling us to take a big piece of tissue from the lining of the cyst, which is actually where the pathology is. So we wanted to, this group wants to compare the yield of diagnosing a cystic neoplasm based on cyst fluid analysis, cyst fluid cytology, or actually biopsying the wall of the cyst. This comes to us from the Kansas City VA. EUS guided through the needle biopsy versus just FNA of pancreatic cysts. This isn't new. This has been out for a couple of years. So what this group did was a systematic review and meta-analysis of 6 different studies to look at the diagnostic yield to see whether through the needle biopsy was superior to fine needle aspiration. And as you can see there, it was 83% versus about 60%. So you do get a better outcome if you biopsy the wall of the cyst. Adverse events were few, and the technique is not that much more difficult than what's involved with an endoscopic ultrasound of fine needle aspiration. Here are the different studies. Here's a forest plot, and it's just showing you that there's a statistical advantage favoring through the needle biopsy for cystic neoplasms. All right, switch gears again. Let's look at EUS-guided treatment of insulinomas. Pancreatic insulinoma is the most common pancreatic neuroendocrine tumor. Here, treating tumors by radiofrequency ablation. Now, for a long time, the role of the EUS was diagnostic, and as with so much of endoscopy, it's moving from diagnostic to therapeutic. In this case, looking at the long-term follow-up of patients, the study comes to us from the Asian Institute in Hyderabad, looking at following patients every 3 months for a year, then every 6 months for a year, and then every year. 10 insulinoma patients, 13 lesions. And what happens to these patients over time is the tumor decreased in 10 of 14 lesions, undetectable in 6, and the clinical improvement remained for several years. Again, with limited adverse events given the RFA. Here's a study, multi-center study coming out of Lyon, France. Again, pancreatic neuroendocrine tumors and also now IPMNs, looking at, again, radiofrequency treatment. For the neuroendocrine tumors, 12 patients with 14 neuroendocrine tumors, 16 patients with IPMNs, and the outcome after RFA. And again, looking anywhere from 3 to 4 years. There were no delayed complications. Of the 12 patients with the 14 neuroendocrine tumors, 13 completely disappeared, suggesting that the RFA treatment was totally effective in those patients. There was no recurrence, either chemically or by imaging. And the 17 patients with MCNs, 11 had complete disappearance. So again, we're looking at the evolution of diagnostic EUS to therapeutic EUS. A couple more points to make. One is endoscopic transmission of infection. So we'll switch gears again. This is a GI endoscopy clearance of North America. I had the real pleasure of editing this. It just came out in October. And it looked at, what's happened to the field really since those several outbreaks of CRE, not just in the United States, but around the world. This year's abstracts on the subject, this one comes to us from Bangkok, Thailand, and it looks at the new duodenoscope with a detachable cap. The group did high-level disinfection and reprocessing, and then testing with adenosine triphosphate, ATP, as a surrogate for bacterial or biological activity. They did 108 ERCPs with a Fuji duodenoscope with a removable cap. Half underwent cleaning with the cap in place, simulating what we're currently using, most of us on the market. And half underwent cleaning without the cap. Here you can see what it looks like, the tip of the duodenoscope with and without the cap, and the enhanced access to the elevator and the backside of the elevator recess, which is thought to be one of the areas that harbors bacterial debris even after reprocessing. What they found was significantly less ATP when you disinfect scopes with the removable cap removed. Interestingly, when you culture these areas, including the elevator recesses, you don't culture any, or they didn't in the study, in the 108, culture any pathogenic bacteria. They had one low concern organism, but ATP is their surrogate. They were able to do away with more of the biologically active debris. So something to keep in mind when you're shopping for duodenoscopes. Also, this one from Hopkins, instead of shopping for duodenoscopes, they want to sell you a device that you can use to seal the tip of your duodenoscope to prevent biofilm, both on the elevator recesses, but also through the accessory channel. It's a device that should reduce costs, because you will, if this actually works, then you wouldn't have to buy new endoscopes. Simply use this device on your existing endoscope. They tested this by applying a solution of E. coli and then simulating an ERCP for 30 minutes. Simulating an ERCP means, the elevator going up and down and accessories going in and out of the accessory channel, and then culturing the endoscopes to see whether or not this device had an impact. Here are some images from the abstract showing how this cap fits over the tip of the duodenoscope and not only covers the lens, but it also goes up inside the accessory channel, which is also thought to be a reservoir that harbors bacterial debris after a procedure. They saw that this actually was a statistically significant improvement, both for protecting patients and scopes. The full paper was published in GIE earlier this year. Cost effectiveness, they did not do a cost effectiveness analysis, but it certainly would appear that it would be. Last thing I want to talk about just for a moment is treatment of obesity. So much interest in this year's abstracts. Surgical sleeve surgical gastric sleeve, as you can see on the left, a reduction of the gastric volume by about 80%, leaving just a lesser curvature as a sleeve to the duodenum. And on the right, the endoscopic sleeve gastroplasty, where you simply suture, it's not simple at all, but you suture the stomach and you create the same sort of gastric sleeve, but do it endoscopically rather than operatively. This study from Madrid, Spain, actually multi-center, looking at that technique, as well as reducing the outlet of the gastric pouch after bypass surgery. Something else we can do endoscopically. This was a study, this was remarkable. This was 800 patients, 6 European centers, 5 countries, Spain, France, Italy, Germany, Belgium. 800 patients, the majority of which underwent the endoscopic sleeve gastroplasty, 764 over 800, so we'll just focus on that. Turns out how you suture this, and I won't get into the details, but the pattern of suturing made a difference, but they were all very effective. They looked at these patients at 6 months and 12 months, and they saw a tremendous total body weight loss as a percentage, 12, 15, and 18%, and BMI decline, again at 6 months. 90% had more than, 90% of the patients had more than 10% total body weight loss, using at least one of these more effective patterns I can show you in a moment. And at 12 months, it was even more effective. So I think this is probably one of the largest registries of endoscopic sleeve gastroplasty, and it's just the outcome truly remarkable. Here's just one of those patterns. This was the more effective one, called the U pattern. It's too technical to be presented, I think, in abstract form, but it does show that they were very selective in how they created their registry. And one of the things they looked at was how the technique was done, and they were able to show superiority using one technique over another. So as obesity becomes a greater and greater problem here in the United States, we're, as endoscopists, having a greater and greater role, as shown during abstracts presented at this year. I'll stop there, and thank you. Thank you all very much.